Good afternoon, everyone. Thank you for your introduction. And in the first place, I would like to thank the scientific committee of the AAO for this kind invitation. I'm very honored to be here again in the AAO for this lecture. My lecture is going to be about clear aligners and TADs in complex malocclusions, and I'm going to talk about biomechanics, tips, limitations, and more. I'm a full professor at the University of Valencia in the orthodontics program. I'm also co-director of our program and dentistry vice dean at the same university. And I had the honor to receive in 2018 the CDAVO Case Report of the Year Award for an article published in the AJODO. The year after 2019, I gave a lecture in LA. So this is going to be my second lecture, and I'm very honored about it. I come from the city of Valencia, the third largest city in Spain and one of the oldest on the shore of the Mediterranean Sea. We also have a new area, as you can see in the pictures. I have been involved teaching at the university for 23 years in the orthodontic program. You can see the residents over there with some professors that are here with me today. So our co-director is Dr. Gandia. So, among other programs, we have been running an exchange program with the University of Minnesota for the last 7 years. Thanks to the collaboration of Dr. Larson and Lanchon from the University of Minnesota and Dr. Gandia Garcia and myself from the University of Spain. This program, as you can see in the pictures, we can see the residents from Spain and Minnesota in the United States and in Spain, and it's a very successful exchange program, and we hope we continue for the future. So I declare I don't have any financial interest of any of the progress I may be discussing in this presentation. Let's start taking a look at these two articles published by our investigation group at our university about current trends in orthodontic journals in the last years. Both of them conclude that the most frequently cited topic in the last year has been TADs. So this reiterates my thinking that TADs are completely changing our orthodontic treatments. If we take a look at this third article, published again by our investigation group about what kind of orthodontic treatment do other patients prefer, it concludes that they want an aesthetic treatment, fast, with no compliance, and of course, with no reduction in the quality of life. You can scan every QR you see on the slide and get the article. And if I show an article that you cannot scan, I will email it to you if you ask me for it. So when I saw this banner at the MIT last year about we are smart enough to know we are smart together, reminds me that if we use clear aligners combined with TADs, we are going to be smart enough to treat more complex cases. So let's start with the anterior-posterior correction in class 2 cases, and I'm going to show you two clinical cases that are going to let me show some ideas and tips with you for the next 30 minutes. This is my first patient who came to my office complaining of incisor crowding. His humble request was that he didn't want premolar extractions and he wanted to be treated with aligners. There was an incomplete molar and canine class 2 with increased overjet, overbite, and negative incisor torque. If you take a look at the upper and lower arch, he presented a severe negative discrepancy, and the present and the upper right femolar was not present anymore and had just been obstructed. He also presented an increased curve of speed. The initial panel shows the presence of the upper right femolar because the panel was taken before the picture. This is a negative aspect if we want to distalize the upper arch. The initial SEF analysis shows skeletal class 2 with a brachyfacial pattern, an increased overjet and overbite, and very negative torque. So, how would you treat this case? From my point of view, there are 5 key points in this case. There are 2 positive aspects and 3 negative ones. One of the positive aspects is that we have a posterior negative torque. You know, when we are correcting this torque, we are creating space that help us to solve the negative discrepancy. The other positive factors is that the incisors are trilingual. So when we are uprighting those incisors, we are creating space and flattening the curve of speed. But on the other hand, the negative aspects are, first, the presence of the upper right femolar that was obstructed in advance. Secondly, we have a very negative discrepancy that has to be corrected. And lastly, we have the class 2 itself. So, if we take a look at this drawing made by ourselves, we can see how while we are correcting the negative posterior torque, we are creating space and making expansion. So that's the way that we are correcting some of the negative discrepancy. After saying all the diagnosis, what about the treatment plan? How would you treat this case? Well, I'm going to correct the anterior posterior correction, and I'm going to distalize the upper arch. For that, I'm going to place one TAT in the upper right tuberosity, and before that, I have to extract the third molar. For me, placing TATs in teenagers or other patients is quite easy nowadays. See, most of them wear piercings around the mouth. So I just tell them that I'm going to place another piercing inside the mouth that is going to help me to treat more complex cases in an easier way, faster, and with no compliance. So I published this technique in the AJO-DO years ago. You can take a look at this article, another clinical case. But in this article is described with brackets. Today I'm going to describe it with aligners. So in this drawing, made by us as well, you can see how first we place the right upper TAT in the right maxillary tuberosity. The TAT is 12 by 2. Secondly, we bone labial and lingual bottoms in the first and second molar, and we activate the elastomeric power change, and everything is controlled with the clear aligners. You can see this technique again in these photos. First, we place the TAT, we bone the labial and lingual bottoms, we activated them with the elastomeric power change, and everything is controlled by the aligner. So, I'm going to describe 8 key points that, from my point of view, contribute to the success of TATs in this area. The first one is gum and bone quality and anatomy of the patient. So, we published these articles years ago, and we identified 3 different types of tuberosity, as you can see on the slide. Type 1, 2, and 3, depending on width, height, and length. So these should be taken into account when we are going to place a TAT in this area. Key point 2 is the driver, the insertion torque, and of course the Atlantic skills. There are two options to place a TAD, as we all know. I will recommend the first one that for me is the best, to use the angle motor handpiece, because it accesses the tuberosity very easily and the patient doesn't have to open the mouth that much. You can see this video from another patient with brackets, but the technique is the same. We use the angle motor handpiece, we place the TAD parallel to the second molar, and the length that I say is 12 by 2 millimeters, and we do it with a very low insertion torque, 15 newtons. And we have to keep in mind that we have to place the TAD separated from the molar so we can distalize the second molar. The third key point is the TAD head, length, and diameter. As I showed you before, length should be something between 12 and 14, and later I will show you how this is very important. The head doesn't matter very much in these cases since the TAD is very posterior. And the third thing is the diameter that has to be 2 millimeters. In this review published by our team again, it says what are the factors that contribute to the success of mini screws. And one of them, as I told you before, is the length of the mini implant. So keep in mind that we can't use a TAD less than 12 millimeters. What about key point 4? Key point 4 for me is the most important since it's appropriate biomechanics. And I'm going to give you 5 tips for this technique. The first tip, as I said, is to place the TAD separated from the second molar, enough so it doesn't limitate our distalization. Second tip is to place labial and lingual bottoms, as you can see in the drawing and in the picture. Third tip will be to have, of course, the aligner cut. But in the case that we change the plant treatment during it or we don't have, it's quite easy because we have our plier to make the cuts. Tip number 4 will be to use the same elastomeric power change section in order to distalize both lingual and labial at the same time to avoid side effects on one side traction. And finally, tip number 5 is where to put the TAD. If you take a look at the drawing or at the picture, you can see that we should place the TAD just in the middle. Because if we place it lingually, we are going to get compression of the arch. So the better is in the middle or a little bit labial. What about key point 5? Inclination, distance to the root, and height of the TAD. When we talk about inclination of the TAD, we have 3 options. Option A, B, and C. Option C will be the best one, since the TAD is parallel to the molar, so it doesn't cause any damage to the root of the teeth as option A, or it doesn't limitate distalization as option B. When we talk about height of the TAD, we also have 3 options here, A, B, and C again. The best option would be option A, since the TAD is at the same level as the bottom, so we just get distalization. But in the case that we want intrusion or extrusion of the molar, as you're going to see right now, we can place the bottom above or below. So that will be ideal for correct open bites or overbites. What about load force? Key point 6 is load force. That should be something between 2 and 4. And what about key point 7? Key point 7 is the time that we should wait between placing the TED and activate it so we can load it immediately. We should change our power change every 3 or 4 weeks because, as we can see in this paper published by us, the power change decays after those weeks. And keep in mind that we have to coordinate very well our power change and our clean check and aligner. And last but not least, we have to make a very good X-ray control. I strongly recommend to take a panel, especially at the beginning, when we are placing these long TADs between 12 and 14, in order not to perforate the maxillary sinus, as you can see in the panel. So, if we are going to extract third molar, I recommend you to wait between 3 and 6 months between the extraction of the molar and placing the TAD in order to have good bone. But what happens is some problems occur during the treatment because problems can occur. I'm going to enumerate 4 possible problems that may occur during this treatment. The first one is that food impactation can occur into the diastemas because we are creating a lot of diastemas. So that may cause soft tissue irritation. Second problem can be the impactation of the power change and the TED. And that occurs when we are using a short TED. Problem number 3 is the appearance of interproximal caries that were already present, but we didn't see them before. So we have to explain the patient about it. And finally, now problem number 4 is that what happens when our TED gets stuck to the molar. That can occur when we distalize a lot, as you can see in 4A, or if we place our TED not parallel to the second molar, as you can see in 4B. In those cases, when we want to take off our TED, we are not going to be able to do it. So I recommend to use the angle molar handpiece again, but to use the appropriate head. The head on red that clamps the TED will not be able to get used since we are not going to have space. So I strongly recommend to use the head in green that doesn't clamp the TED but get inserted into the TED. So it's going to be very easy to remove the TED when we are done. So let's take a look at the occlusal view of the clean check and the mouth at the same time, because we want that the clean check works exactly as the mouth. We know, we have seen how placing one TAD in the right maxillary tuberosity, we create enough space to correct class 2 and the negative discrepancy. In the frontal view, we see that at the same time that we are distalizing and correcting negative torque, we are making intrusion of the upper incisors and correcting midline that was also shift. And at the end of the treatment, you will see in the pictures that I used some metallics bottoms with elastics in order to correct the occlusion. So that was necessary in this case to get a very good occlusion. The lateral view shows that I used an asymmetrical biomechanics. The right side had a lot of diastemas, because remember about the class 2, while the left side didn't have as much diastemas. So they work in a different way, and we have to know that. We knew that from the beginning. And you will see the metallic bottoms in order to use elastic at the end of the treatment to have a perfect occlusion, as you can see on the slide in the pictures. So, on the slide, we can see a comparison of the patient's smile before and after treatment. Treatment took just 24 months. The patient was very happy with the result, and you can agree with me that the smile is much wider right now. The profile didn't change, and the nasolabial angle was stable, which is very important in these cases that we distalize the upper arch. Class 1 was achieved with a correct overjet, overbite, and incisor torque. And at the end, we get a good occlusion, function, and aesthetics. Upper and lower arches had their negative discrepancy corrected, and the curve of Spee was flattened. The final panel shows that a very good root parallelism was achieved at the end of the treatment, and final self-analysis shows good class 1, overjet, overbite, and incisor torque. But let's take this a step further, and let's see another challenging clinical case. This second patient came to my office complaining of incisor protrusion, gummy smile, and a narrow arch. And as the previous patient, his humble request was that he didn't want premolar extractions and wanted to be treated with aligners. There was a complete molar and canine class 2 relationship with increased overjet, overbite, and negative torque at the posterior teeth. The upper and lower arch presented severe negative discrepancy, and all third molars were present in this case. The curve of Spee was also increased. The initial panel shows the third molars that had to be extracted, as I said before, because we want to distalize the upper arch. And the initial self-analysis show a skeletal class 2 with a brachyfacial partner, increased overjet, and overbite. So how will you treat this case again? For me, there are 5 key points, 2 positive things and 3 negative ones. We have again negative posterior torque. We have gummy smile that can be correct because we are going to intrude the upper incisors. And on the other hand, the negative aspect is that we have a maxillary compression, we have a negative discrepancy, and the complete class 2 itself. So I'm going to treat this patient in the similar way as the previous one, but in this time we are going to make a symmetrical biomechanics using 2 TADs in the upper maxillary tuberosity. Third molars were extracted at the beginning of the treatment. You see the drawing again, TADs 12/2, ounces between 2 and 4, and we boned labial and lingual bottoms, and the aligners is the one that control all the movements. We always do a follow-up X-ray in order to see how we are going, and as you see in this patient, he had the upper third molar extracted at the beginning, but then he extracted the lower third molar at the end. You see again the occlusive view of the upper arch. We start the distalization just from the beginning of the treatment, creating a lot of diastemas to correct the class 2 and the discrepancy. You can see how we change the art form. And then from the frontal view, you can see again how we are correcting the class 2, the posterior torque, and how we are making intrusion of the upper incisors at the same time. In this case, I didn't use any elastics because the occlusion was correct at the end of the treatment with aligners. The lateral view shows a symmetrical biomechanics in this case. You see how much diastemas we can open with this set in this area, distalizing both first and second molar at the same time, at the time that we are correcting posterior torque and intrusion. So, on these slides, we can see a comparison of the smile of the patient. And as you all agree with me that we have a very wider smile, the gummy smile has been corrected, and the profile, if we take a look with more detail, you can see here that the nasolabial angle is stable, the gummy smile is gone, and the overjet is reduced. We get a class 1 with correct overjet, overbite, incisor torque, and good occlusion, statics, and function. Treatment took 24 months in this case. The final occlusive view from the upper and lower arch shows that all the molars were structured and the negative discrepancy was corrected as the curve of speed. The final panel shows that very good root parallelism was achieved at the end of the treatment, and the self-analysis show a good class 1, overjet, overbite, and good torque. The superimposition in this case shows that the profile hasn't changed very much. That was one of our objectives. And the molar distalization in the upper arch has been done in a very good way. But what about stability? Is distalization with TED stable? Well, after a 2-year follow-up period of this patient, everything was correct and stable. Everything was perfect, the patient was very happy with the results, and the panel and the self-analysis didn't show any change. So from my experience, of course I don't have anything published about this, but from my experience, yes, it's a stable treatment. And just to finish, I want to finish with this famous Einstein quote that says that the mind that opens to a new idea never returns to its original size. And I like it very much because it reminds me how I feel about using TED and clear aligners together. Now that I'm using and correcting this kind of malocclusion this way, I cannot think about another treatment I used to do before. But let me tell you one last thing, that at the end what really matters is our patient smiles. So thank you very much. I thank the AO Scientific Committee again for this kind invitation. It has been a pleasure for me, and I thank you all for being here. And by the way, remember to take a moment and complete our session evaluation now. Thank you very much.